So we have Dr. Sequist here. So he's currently the Chief Medical Officer of Mass General Brigham. So he serves as the Director of the Four Directions Summer Research Program that we heard from Tina earlier today. Also, he serves as the Director of the Brigham Women's Hospital Physician Outreach Program with Indian Health Services. So Dr. Sequist, thank you for joining us today.
Sorry, I was on mute. Thanks so much. Just can I confirm for timing, you want me to go for about 20 minutes? Does that sound right?
Sure, that works for us.
Okay, and I'm going to talk not about the Four Directions program, but about the Indian Health Service program.
Yes.
I understand. Yep, Tina already talked about the Four Directions program. Great. So let me I can share my slides now. Is that good?
Yes, thank you.
All right, great. All right, so I'm going to share with you our sort of 10 or so year journey around what we call the outreach program with the Indian Health Service, a program that originally run out of Brigham and Women's Hospital and now is a Mass General Brigham wide initiative. So this is a program that goes back to 2008. It was sort of launched as a pilot back at that time, sort of smaller scale, and has expanded, and I'll talk more about how it's expanded and what its goals are. I do like to always sort of call out, it was really the sort of inspired leadership of Phyllis Jen, a primary care physician at Brigham and Women's Hospital, who spearheaded a lot of the earlier work in relationship forming to get this program off the ground. So what is the mission of our program? It really is ultimately, like many programs, to improve the health status of the American Indian population. We try to do it in a very specific way, which is we are trying to increase the capacity of the Indian Health Service hospitals and providers to treat increasingly complex conditions and enable care that otherwise may need to be referred outside of the hospital to settings where it's actually not as accessible to patients and to providers. We do this by working with the Indian Health Service. We try to build their capacity in a sustainable way so that they can provide care through clinical programs that when we are not there in providing volunteer work, that those clinical programs can still continue. So how do we do this? And I'll walk through some of the models a little bit, but we do education, clinical training through our experts that we have, clinical experts that we have here in Boston. We do consultation, long distance consultation as well through telemedicine programs, and have been doing that for the past decade. We actually send our faculty out through what are basically volunteer opportunities. Our physician faculty and other clinicians go out to the Navajo Nation. They on site do clinical teaching and actually clinical care. And ultimately, like, we really do feel like we're trying to build a long-lasting collaboration between our physicians here at Mass General Brigham and Brigham and Women's Hospital and our colleagues in the Indian Health Service. One of the unintended benefits, and I'll show you a little bit more about this in a few minutes, has been that it actually is quite a rewarding activity for our physicians here in Boston to participate in, and it's become part of our wellness portfolio across Mass General Brigham. So I'm sure you've heard a lot about the American Indian Alaska Native population in the country today, so I won't go into a lot of details on this, but suffice it to say that the largest proportion of this population is really west of the Mississippi River and is in very clustered geographic regions, not accidentally in clustered regions. But we are talking about the program that we do at the Navajo Nation, which is in the Four Corners area of the United States, where Colorado, Utah, Arizona, and New Mexico come together. And you can see here on the map where the Navajo Nation is outlined. Quite a big area, right? Probably 3 times bigger than 3 times the size of Massachusetts, but much less, obviously, much less sparsely populated. Just background, and I know you just got a whole talk on the Indian Health Service, so I won't go into very significant detail, but a health system that provides care for millions of American Indians across many hospitals and health centers across the country. There are a couple of challenges that we have been trying to support with the Navajo Nation. The first is that there can be quite limited access to specialty services. There's been a lot of research over the years that have shown that many of these hospitals and health stations really do have limited access to surgical and medical specialties. There is significant underfunding of the Indian Health Service compared to other branches of the federal healthcare system, including the VA and Medicare. Those numbers that you see there are really per patient per year expenses. There is very significant in some parts of the country geographic isolation, but also what we have found is professional isolation as you try to get more specialists in these areas to provide, again, more specialized care. And then, you know, as a result of this, there can be significant difficulty in recruiting health professionals, and there is very frequently a significant vacancy rate among physicians, among dentists, among pharmacists, among nurses, to name some of the health professions that there are vacancy rates for. So getting back to the Navajo Nation and the outreach program that we have out of Mass General Brigham, we are working with the Navajo Nation, which is just highlighted here, one of the largest communities in the country, and again in a land area that's you know, nearly 3 times the size of Massachusetts, just to put it in perspective for those here in Boston. There are very significant social determinants of health that impact health outcomes among many American Indian communities across the country, and I think the Navajo Nation is not different in this space. There are food deserts, very significant challenges in getting access to fresh and healthy foods. There is significant poverty, 40% poverty rates. This is a result of significant unemployment in these areas. There are also very substantial challenges in access to basic infrastructure, including indoor plumbing, electricity, broadband internet, which became a big issue during the COVID pandemic, as well as the road infrastructure and public transportation options as well. So all of these things are present in many impoverished communities, but I would say among American Indian communities, they can be present at levels that you just don't typically see in the rest of the country, and present a real challenge to the delivery of healthcare and to achieving optimal health outcomes. So when our program started, we started working with these 3 communities that you see here, Shiprock, Gallup, and Chinle. You can see here that the nearest access to tertiary facilities, either in Albuquerque or Phoenix, are quite far away from any of these sites. And you know, there are, in addition to being quite far away, there are obviously significant travel constraints that are experienced by the native population on the Navajo Nation, as well as significant language and cultural barriers that are experienced when they are traveling to these distant hospitals. So what we were trying to do with the outreach program is really try to address some of these challenges that you see here. I'm going to skip through this just in the spirit of time, but suffice it to say that there are very significant health disparities among American Indians that have persisted for many, many years, both in the chronic disease space as well as things like acute illnesses like influenza and pneumonia. We know that these disparities were exacerbated during the COVID-19 pandemic, where the native population overall was much more likely and had higher risk of poor outcomes compared to the white population in the US. A lot of these disparities were particularly exacerbated in the Navajo Nation. You know, that unfortunately the death toll was significantly higher per person among the American Indian population compared to the general population. So that doesn't mean that there haven't been significant successes, and we should highlight our successes and learn from them. There have been very successful vaccination efforts among all American Indian communities, and you can see the numbers here among the Navajo Nation, where a lot of work went into improving the vaccination rate. So just diving into our program itself, our program, our volunteerism program, the Indian Health Service outreach program, really has kind of 4 components, as you can see here. We send clinicians out for on-site visits where they stay anywhere from 1 to 2 weeks at Gallup, Shiprock, or Chinle. We also have a component where there's remote teaching, where we conduct CME and direct patient consultation efforts. We do these distant consultations also through email, phone, and now Zoom, which is something new, you know, since the pandemic started. And then we also have a mentoring program, almost like a clinical exchange program, where we bring providers, clinicians, physicians, nurse leaders from the Indian Health Service to Boston to conduct targeted training, whether that be sort of critical care training or otherwise. So since our program has started, we've had over nearly 350 on-site visits, that meaning faculty from or physicians from Boston, from Mass General Brigham, traveling out to the Navajo Nation to provide patient care and to do teaching out there. We have had many of our faculty, you can see we've had 172 faculty go out, which means that many of our faculty have gone on return visits and have established that longer term continuity relationship that we have often strived for. We have really pushed our program to include all of the specialties across our system. We've had specific specialties that have been particularly engaged, including dermatology, emergency medicine, psychiatry, that you can see outlined here. But it is really a pretty broad-based effort in terms of the volunteers that we have going out there. We also do, as I said before, regular remote teaching. We do at least 20 to 25 CME interactive video conferences per year. This has actually been also helpful for our colleagues in the Indian Health Service when travel budgets have been more limited within their hospital or their area, and that it is a mechanism where they can still achieve their required CME. We actually create access to these CME lectures to all of the Indian Health Service physicians through a website where they can download and watch all of these teaching seminars. And I'm just going to skip that, just showing where it was, where these are stored. And then, like I said before, we have brought many clinicians, 23 clinicians to Boston, Indian Health Service clinicians, where they get skills training. And so where do we use this in particular? This model works when we feel like there is an important aspect of care that the Indian Health Service clinicians have asked for and would benefit from training on, but that care is sufficiently rare at their hospital that if we were to send someone out there to be trained, we actually wouldn't be able to guarantee that type of care would be necessary during that week that our providers are out there. For example, if we wanted to teach, provide education on acute respiratory distress syndrome or ARDS, we could send our pulmonary and critical care specialists out there, but they may not have a patient who currently has that need. And so what we found is a better model is that we would bring those clinicians out to Boston, where we very often have patients in a higher volume with those kinds of specialized care needs, and we can provide that training on site here in Boston. So we have listed here a lot of different examples of the types of care that we have engaged in over time with the Indian Health Service. You can see ranging from various behavioral health initiatives, Suboxone training, to other clinical initiatives in cardiology, neurology, stroke care, a large and extensive dermatology initiative, as well as non-clinical programs. I guess maybe non-clinical, maybe not the best word, but we've done training in service excellence and leadership training, how to handle difficult and challenging scenarios inside of your hospital. So we have continued this work during COVID-19. We've had less visits initially less visits as travel was restricted, but increasingly did start conducting visits again. The work that we did during the COVID-19 pandemic ranged from emergency medicine support to significant amounts of mental health support, in particular to Indian Health Service providers as well during the challenges of the COVID-19 pandemic. We continued all of our remote education and did a lot with our own supply chain to try to provide personal protective equipment to the providers on Navajo Nation, on our partner hospitals that we've been working with. I would say that I won't talk in detail about the COVID-19 pandemic on the Navajo Nation, but this is really in many American Indian communities a very traumatic event. We hope to be able to continue to provide support related to COVID-19 as an expansion of our efforts with them. I put up here, I had mentioned before that we have found that our volunteers that are going out to work on the Navajo Nation have really felt that this is also sort of a well-being effort in intervention for themselves. I just put up some quotes here from our volunteers to just give you a sense of some of the benefits that our providers express when they go out there. So our primary goal is to improve the health and well-being of the residents of the Navajo Nation. We have a secondary goal of improving the capacity of the Indian Health Service providers to provide that care. There is this tertiary benefit that we are finding, which is that our volunteers that go out there actually are finding it to be something that is actually helpful for their own health and well-being, where they feel like they are really contributing in a way that perhaps they haven't been able to find in their day-to-day jobs here in Boston. So this program has actually become part of our well-being portfolio of efforts across Mass General Brigham as well. I'll leave you just with some of the feedback that we've gotten from our colleagues in the Indian Health Service, which is that we hope that we've been able to expand their ability to provide care for these patients in a way that wasn't available before, increase access to specialty care, and increase access to telemedicine consultation and continuing medical education. And we hope that this presents a model that can be expanded to other American Indian communities as well. So I'll say thank you very much. I'll end with just saying this is work that has always been quite personal to me. I am a member of the Taos Pueblo tribe in New Mexico, which is actually not that far from the Navajo Nation. And I just think that, our ability for academic medical centers to contribute in our areas of expertise is something that we should, expand greatly as we have a commitment to improving the health and well-being of the American Indian population. So thank you so much. And I'll end there and I'll stop sharing my screen.
All right, Dr. Sequist, thank you so much for that talk. So I just want to ask you some questions. So is it easy to recruit physicians from Mass General Brigham to go on these trips?
It actually, yes. So we have had an overwhelming response, and actually to the extent of these hospitals are smallish, that I'm talking about out in the Navajo Nation. And so we have to limit the amount of volunteers because you can only have so many volunteers at a time at any given hospital. There are some areas, just to be clear though, where it can be more challenging to recruit specialists. I wouldn't say that it's been 100% perfect, but we have had a lot of volunteers over time, and that hasn't been our primary challenge.
Oh, excellent. And then someone asked from the audience, if physicians not at Mass General Brigham, if they can volunteer to be a part of this program. So
not via our program, only because we have specific basically use agreements with the Indian Health Service that are specific to our hospitals within Mass General Brigham. And we have worked out all the details of malpractice coverage and otherwise because we are providing clinical care. But I would say I wouldn't let that discourage folks from trying to establish separate relationships with any other tribal communities as well.
Excellent. And then, so your program, brings physicians to Native communities, but Dr. Christensen talked a little bit about bringing natives to tertiary referral centers, especially for cancer care. Do you think, is there any kind of program like that at Mass General Brigham?
We don't have an initiative like that. I mean, again, I think it depends on, the goals and the specific needs of the community that you're working with. When we started working with the Navajo Nation, it was very clear that one of the biggest deficits that was there was access to specialty care. So, most of the physicians, the majority of the physicians in the Indian Health Service would be in the primary care space, whether that's family practice or internal medicine or pediatrics and, OBGYN, general surgery, but getting access to other specialties, medical specialties, cardiology, rheumatology, dermatology, surgical specialties, urology or otolaryngology. Those are the areas when we partnered with the community there, really rose to the top pretty quickly as areas of need. Cancer care is a challenging one, right? Because it's ongoing care. So we provide care in these sort of on-site visits over a couple of weeks, followed by remote care to follow up. And if you get into the cancer care space, right, you start thinking about chemotherapy and surgical care and such. It's not undoable, but it's a sort of a different set of challenges. Right.
And then also we heard a lot about your hand in founding the Four Directions program. So I wonder if you just give us a little bit about your pathway and then kind of your experience with, why you would even found the Four Directions program.
So I'm American Indian. I'm Taos Pueblo. I am the first person in my family to finish college, and so the first person to go to medical school. And I feel like over time, I've had a good deal of luck in terms of my career trajectory, and a lot of the things that pathways that I basically stumbled into over time. I felt pretty strongly that there's no need that people should have to stumble into those pathways. That there is a playbook out there, and it's just a playbook that I never saw in terms of going from college to medical school, to residency and career paths as a physician. And one of the goals that many of us, the few of us that worked on this Four Directions program very early on had, was to help kids like us. Basically, remember, I was like 21 years old at the time. I won't tell you how old I am now. It was a long time ago. That, you know, to help kids like us at the time, like, feel like they knew the rules of the game in which they were playing. Because it's not a level playing field if only half of the, you know, people have the playbook, right? And the other half of the people don't. And so that was really the impetus for this program, was to say, how can we help other Native students know the information that they need to know? That's the first thing. The second is, how can we give them the set of experiences to make the right decisions around their career choices, right? So that's like research experience, clinical shadowing, and volunteering experiences. And then the third thing was, how do we set people up with the social capital? Although, again, when I was 21, I'm pretty sure I didn't know what the word social capital meant. But like, how do we set people up with the social capital so they have the connections to be able to succeed? Because that is just as important, right, as knowing the rules of the road and what you're trying to accomplish. So we do lots of social networking events, right, with different faculty, with different students, graduate students, and admissions counselors, and everyone else while they're here in Boston. We feel like that set of initiatives overall can put people in a better place, because it takes a long time, and in many cases you never recover from that knowledge deficit. Like I am, you know, let's say 20 years into my career here at Harvard, and I still, you know, come up against, like, I just don't know certain things, right? Because I've not had exposure to those broader networks over time.
Okay. Yeah, and then so I guess, you know, now that you've progressed into your career, you know, how else are you, as you know, the CMO, how else are you bringing Native priorities into Mass General Brigham? You know, obviously, like, your outreach program is one of them, and then the Four Directions program is obviously as a medical student. Are there any other initiatives that you have?
Well, you know, what I would like to see is for us to have more Native faculty at Harvard Medical School overall, and, you know, within Mass General Brigham as well. I think that, like many other racial groups, Black physicians, Latino physicians, Native physicians, over the past 30 years, we at Harvard, but also the medical community across the whole country, has not made, I was going to say has not made enough progress. If you look at the data, we haven't made really any progress in terms of increasing those numbers, if we're sort of transparent about it. So for me, it would be, we should continue to recruit and retain talented American Indian students, Black students, Latino students, so that we can, you know, build up a stronger sort of bench of future leaders and care providers.
All right, great. So I think we're a little bit early, but I think we can open it up to the rest of the speakers, and then kind of do a little question and answer panel that's open for anyone. Okay, great. Okay, so I guess Dr. Christensen, I guess I didn't ask you specifically about your pathway into becoming a physician and any barriers that you face along the way.
Thank you for the question. I grew up in Gallup, New Mexico, which is border town of Navajo Nation. I am a member of the Navajo Nation. And for me, it was an interesting journey. I think maybe because I was naive, or maybe just maybe a little oblivious. I never thought there was anything I couldn't do that I really thought I wanted to do. So I left home all those many years ago and went to Harvard as an undergraduate. And you can imagine that culture change between rural New Mexico and Boston, or Cambridge, actually. And I have to say, it was one of the greatest experiences I had. I met so many very special people, and what I'm very struck by, even hearing Dr. Sequist, is how many people from there are of service. So I learned a lot about being of service, and then progressed on to medical school in Philadelphia, and then did my residencies in fellowships in New Jersey. Again, going into surgery, never once thought I shouldn't be a surgeon. Boy, this might be hard to be a surgeon. I just thought, this is what I love to do. This is what I want to do. And I just looked forward. I think the one thing I did learn though is that you always have to lift others up. You always have to take that time to mentor. That is so key to empower our kids. And I love the programs we've talked about today, because that means so much to a student. You know, I can recall back to my undergraduate meeting new American and Alaska Native students and just saying, you're going to be fine. Let me show you around. And maybe just those few minutes made a big difference to acclimating them to that area, because it is a big jump. It is a huge jump. And so I just feel that I got to be honest, I think I survived through reading so much. I read so much about the rest of the world. I felt like I could kind of transport myself into those worlds. And then I thought, wow, these people are really scared that are showing up. So mentoring became something very important to me. I've taught hundreds of surgical residents, and I'm so proud, not that they're good surgeons, but that they're great humans. It's been my honor, you know, but I think those things are very key to reach down and really make sure everybody has a pathway.
Yeah, excellent. Dr. Thompson, are you there?
Yes.
Okay, good.
Hey, how are you?
Good. How are you?
I'm doing well.
So this is one of those rare moments when, so I think we've all talked about mentors and people that are important to our lives and have helped us progress along the pathway. So this is one of those rare moments when I say, here's my mentor, Brian Thompson, who really helped me along my pathway. And so, you know, I talked about in the beginning that I was kind of, I didn't know what I was doing basically. And so he picked me up at an AAIP conference and really showed me the path in getting to going to medical school. So obviously every time I see you, I want to say thank you, Brian. And then I just want you to also, if you could share your pathway into becoming a physician.
Sure, absolutely. Sigoli Scano, Dehahun Jayistani gets. My name is Brian Thompson, and I'm from upstate New York, area called Syracuse, New York, the home of the Haudenosaunee. And it's really a privilege to be a part of your webinar conference today, and really just to actually just seeing some friends that are on the video here, but also just to say hello to you, Cameron. And we're so proud of you here in Syracuse and everything that you do. You're just an amazing doctor. So just yeah, we'll go and a big thank you for all that you do. You know, I'm a NIDA from New York, and I'm the first NIDA to be a physician here in New York State from our nation. The Haudenosaunee are commonly called the Iroquois. You know, my pathway to medicine was always interesting, I'm sure, like everyone else's. I actually was working in quality control on an assembly line, and then there happened to be a medical school spot that I was planning on going to medical school, but taking some time off, and this was over 30 years ago now, and a medical school spot opened up at Upstate. It used to be called SUNY Health Science Center at Syracuse. And I literally was working on an assembly line, got a call and asked if I was interested in coming to medical school. This was on a Friday, starting on a Monday. And it was one of those times when you had to make a decision whether you were going to do it or not. And I chose to do it. And I actually took my MCAT exam after I got into medical school. And so that was kind of an interesting thing. But I never looked back and never stopped trying to give back. You know, I think one of the most defining things about being a Native physician is that we're really Native physician activists. And first, we're Native, Ongwe Hongwe. We're our people. And second, I'm a physician. But third, I think all for Native physicians, because there's such few numbers of them, we're really Native physician activists who really look out for our people. So anyone that's Native that, and like other marginalized groups of individuals, really take it to heart, caring for their people. There's, for me, the most thing that I always, that really makes me feel good about being a physician is we do a lot of our ceremonies and our culture within something called a longhouse. And I'm an OBGYN, so I deliver lots of kids. And I get to deliver kids within my community. And we get our name in the longhouse when we're babies, when we're kids. And it's always, just an incredible experience to be able to deliver someone and see that baby for the first time. And then to watch them get their name and be introduced to the community where I grew up is something that really resonates with me, and something that I will always remember every time I get to participate. So that's just a brief thing about how I got to be into medicine.
Great, thank you very much. So I just wanted to open up the questions to everyone else on the panel. So I feel like we've had a lot of different sections of Native health in pathways, from before medical school age programs, medical school programs, and then physicians working out in the community. So I'm just wondering if has anyone taken in someone else's talk and thought about potentially cross collaboration in these spaces, from whatever space you work in now into a different arena.
I'll jump in. I really enjoyed Dr. Bray's talk, because that is something that the Indian Health Service is very focused on right now, is we're developing GME programs. And I have been working with tribal partners as well, and very happy to meet her virtually, because I think there's a synergy there that needs to exist as we try to advocate for our programs, to make sure that they'll be funded, to make sure that they're sustainable. And then those connections with, the academic universities in each of our areas, I think that creates a lot of other partnership along with just the residency. So that's a space that I think for Indian Health Service that they haven't been in largely. We've been good hosts to many rotating docs and residents, and certainly during COVID, I would never be able to thank all the volunteers enough that came from all over the country that helped us out, and they integrated right in with our teams. They were just amazing. But that tells you there is so much more communication to be had, and so much more connection in a lot of aspects of care. I know I can't provide cancer care in that type of cancer center care in our facilities, but I can hook up with people that do that. I can connect with them. And then I know, we're not going to be the GME guru, but I can hook up with the Oklahoma programs and up in the Mass General, working up in Rosebud and all that. And I think together we're very powerful. And I don't think we've used that power as well as we can. So I do think that it broadens a lot of what we do to, if you will, feed off of each other, learn from each other, and then join together, because it's a pretty awesome group of people that deal with Native medicine and residencies and care. So I'm psyched about that there's so much more potential there, and I'm always happy to meet new people and gain energy from them as well.
So I'll just comment on that, because we do have the 3 residency programs. One of the challenges around that is that they don't qualify for traditional CMS funding for GME. And I think that that's a huge barrier that has to be taken into account. And we submitted teaching health center grants to HRSA last year for to try to get funding for 3 of the programs through the Teaching Health Center program. And they were all denied on initial application because they were deemed ineligible facilities because they really didn't understand how the tribes that were who had compacted for self-governance or self-management of their tribal healthcare centers, how they were structured. And so they denied all those applications. Now, Chief Hoskin is on a special commission HRSA task force right now looking at the Teaching Health Center grant program, and they did reopen another call for applications that closed March 31st. So we resubmitted for our 3 tribally affiliated programs. So those applications are out there, and we're hoping that the HRSA program administrators have been had an opportunity to learn about, because they specifically in that call for funding and for program applicants specifically said that they wanted programs that were working with tribal healthcare centers or Indian Health Services, and then they denied them because of the payment structure associated with them. So that hopefully has been addressed since they did do a specific call for grant opportunities. But right now, those programs are self-funded by the tribes themselves, which is wonderful that they're able to do that today, but we don't know what the financial position will be of those tribes going forward. So it'd be much better to have sustainable funding for those programs.
Great.
Well, let me just give you a little hope. We got our foot in the door with CMS, and I'm going to remember your name so I keep you informed. We are advocating and working as best as we can to create an opportunity for that CMS GME funding. And so we're hopeful that we might be able to find some kind of common path, which would solve the problem of both that program, HRSA, and the VA Mission Act also just came through. And again, they'll help you start a program. They'll place people at your facility, but nothing with the GME funding that we need to sustain these programs. So we're working very hard on that, and we welcome all comers to these meetings because we need that voice. So happy to connect you with that as well.
Okay, great. And then we do have a question from the audience here. So I believe that Dr. Sequist mentioned that there's more primary care physicians on reservations than on specialists, and that there's a need for specialists. I don't know, Dr. Christian, if you can explain why this might be, or even Dr. Bray, in what terms of what medical students are interested in.
Well, I know for the Indian Health Service that we're characteristically primary and preventative care, which is what we do well, and that we hope to keep doing well and just improve that. We're working on some primary care retooling, in fact, right now. I think the problem with a lot of specialists, the specialists are driven by volume. So if you don't have enough volume in a particular area, that person may feel they don't use their skills, they don't have a broad enough experience. It requires you do the adaptation. For example, total joints, you have to have the pre-op, the rehab consultation, make sure the OR equipment, which is an additional cost, because believe me, we don't make money off of specialties in the Indian Health Service. We do a lot of things to be of service to our people. It's not because we're going to make revenue, and that's fine. That's what we're here for. But I think when you go to real specialties, it is hard to sustain that practice sometimes, unless you're in one of our very big facilities. So that's why sometimes sharing them, if you have a private hospital nearby, you can share specialists, which I think is a good model. And then, the referrals with telehealth, after maybe one in-person visit, you can follow up somewhat by telehealth as well. So I think those models work better. And that's why I try to explain very often, to have a true cancer center, the investment in a true cancer center is very difficult, but a good model is the Gallup Indian Medical Center right down the block has a cancer center that UNM put a satellite in our town, and it serves our people extremely well. So that's a good model too, because there's enough patients at that regional hub to support that. But I think it's driven by volume, and then you don't have colleagues. You're kind of by yourself all, there. And we all miss our professional support and our camaraderie and our best practices and things together.
You know, I think it's hard. We're invested in building a primary care network, but that doesn't mean that our students aren't interested in specialties. And so I think that it's out there. I think Dr. Christensen touched on some really important things. The Cherokee Nation, a lot of their specialists are in partnership with the community hospital that is here in Tahlequah, or really it's a multi-specialty group that covers the northeastern part of the state. So our GI group comes out of Tulsa. We have a shared rheumatologist between the city hospital and the Cherokee Nation facility, who also does telehealth visits for the Choctaws. And so you start seeing kind of some of those consortium things to meet the volume need. And it's really a volume issue when you get into some of those. I will tell you from a student perspective, I have a lot of students who would be eligible for things like the IHS scholarship who are a little bit hesitant to take it because of what is perceived as a limitation in what specialties they can pursue for residency programs, because that scholarship is pretty tied to what are traditional primary care-based specialties. Psychiatry is there, emergency medicine is there. So we can debate is emergency medicine a primary care field or not, but those are included. But the subspecialty fellowships are not included. And so the students are a little bit hesitant. What we see a lot is they won't take it when they initially come into school, and they'll get into their second year and they have a little bit, or even their third year, where they have a little bit better sense of what they want to do. And then they'll go ahead and take that scholarship to pay for the remaining 2 years of school. But I think the IHS, the way that IHS scholarship is structured, does encourage our Native American students towards primary care fields. And so there is a little bit of financial pressure there tied to that.
Okay. And also, Dr. Bray, have any other medical schools reached out to you to form the same kind of partnership? Is there going to be a second medical school that's on a Native reservation at some point?
I don't know. I hope so. You know, I mean, we have active conversations. You know, I will tell you that that I think that this is something people are really interested in. You need to be purposeful. You know, we take 50 students a year, so this is a smaller campus, so we can stay very mission focused. Little bit different. You know, if you want me to put on my school administrator hat and talk about, you know, break points, it's really hard to run a medical school with less than about 160 students, unless you've got good donors that are backing a lot of it. So we were kind of in a unique position to be able to open this smaller campus, and there's a lot of ways that you can approach that. But I think it's a meaningful model. And even if people don't open full 4-year campuses that are affiliated with tribes or on tribal land, you know, looking at having 3rd or 4th year campuses. So where you're really moving them out during their clinical rotations, if you've got some of the larger healthcare systems or networks that would be able to support them, I think there's some really meaningful things. And if you can't support that, look at, you know, when we look across the country, we have lots and lots of medical schools that are located adjacent to tribal communities, or even in our urban settings where you've got urban American Indian, Alaskan Native healthcare networks. So how can we, at minimum, how do we get a rotation? You know, how do we set up a 3rd or 4th year rotation so students have the opportunity to be exposed to that? I think lots of schools have the opportunity to develop, you know, the type of tribal track that we have, where we set up rotations where they're able to spend meaningful time doing their clinical rotations. And that may be 1 rotation, it may be 2 rotations, or it may be 5 rotations, but beginning to look at how we allow students and we allow these communities to embrace education in a way that works for them, I think is important. And I think that there's a lot of interest in that in the communities.
Okay, well, thank you for sharing. So I think that, you know, we're able to answer questions throughout the day. So I think we can end the question and answer panel a little bit early. Thank you for all our speakers for being here. Brian, thank you for coming. I really appreciate you being here. So I think that we'll end it here. And then if anyone has any questions, we can definitely send out more information to everyone who's registered. And then we hope you hear from you soon.